Hey there, I'm your animated CRNA guide, but behind me is a real person with over 30 years of experience in anesthesia. Anesthesia Bits brings quick, clear insights for CRNAs, SRNAs, nurses, patients, and curious minds. No face, just facts. Let's dive into a real showstopper in the anesthesia world. Propofol.
Hi there, I'm a Mr. Propofol. Some call me Diprivan, and my friends affectionately call me the milk of amnesia. But don't let my smooth, milky appearance fool you. I pack a big punch, I knock you out fast, and when I'm gone, you don't even know I was there. I'm the biggest and baddest thing that's happened to anesthesia.
Haha, Mr. Propofol sure thinks a lot of himself. But to be fair, he is kind of a big deal. Before Propofol, thiopental was king of IV induction. That changed in the early 1990s when this milky marvel hit the scene. Today, he's the gold standard IV induction agent. And here's what that means. Induction is that critical moment where we take someone from awake to fully unconscious, safely and quickly, so we can start surgery or a procedure. And Propofol? He gets it done in under 30 seconds. Smooth, reliable. Sometimes it can be uncomfortable when injecting, but a little lidocaine can help with that, and Versed usually erases the memory of the entire induction event. Propofol enhances GABA, your brain's calming chemical, at the molecular level, C12H18O. It distributes fast to the brain, usually in one circulation time, but it quickly redistributes to less perfused areas, which leads to rapid reawakening in 5 to 15 minutes. Of course, each patient is different, so always titrate to effect.
Hey there, it's me again, Mr. Propofol. Let's talk about what happens after you push that plunger and send me on my way. First up, volume of distribution. I range from 2 to 8 liters per kilogram. Yeah, I spread out. Some people give me a cozy little kiddie pool, others, full-on Olympic lap pool. I don't judge, I adapt. I'm not the clingy type. I like space. I go straight to the brain because obviously that's where the action is. You go unconscious, I take a bow. But then, I start redistributing to other tissues, muscles, fat, etc. Basically, I crash on every couch in the house. That's why people wake up in 5 to 15 minutes. Not because I'm gone, but because I've left the brain party and slipped out the back door. My half-life? Somewhere between 1 to 5 hours. But don't get excited, that's just how long I hang around in your system. I do my best work in the first few minutes, then coast. Metabolism? That's all liver. Shout out to my cytochrome P450 crew. Those enzymes tear me down like pros. I'm so efficient that my metabolic clearance is faster than hepatic blood flow. I'm not saying I'm impressive, but I'm impressive. Then it's off to the kidneys, where my tidy little metabolites get flushed out. Thanks for the ride, renal system. Oh, and heads up, kids need more of me. Their metabolism is like a squirrel on espresso. Older folks, take it easy. A little goes a long way. So yeah, I show up fast, do the job, spread out, clean up after myself, and ghost like a gentleman. You're welcome.
All right, so now you know how Mr. Propofol swoops in, redistributes, gets metabolized like a rock star in the liver, and pieces out through the kidneys. But where does this diva actually get to perform? Let's roll out the red carpet. He's not just a pretty white emulsion. He stars in OR induction, swooping you from awake to unconscious in under 30 seconds. Boom, curtains down. He's a regular in procedural sedation, like during an EGD or colonoscopy. You're snoring while the scope's exploring. He's cool like that. TIVA? Oh, please. He owns total intravenous anesthesia. No gas or half-mac, no problem. Just a smooth anesthetic with a little help from his opioid entourage. And don't forget the ICU. When patients are ventilated and need to chill, Propofol steps in like, relax, I got this. You focus on healing. I'll handle the sedation playlist. From the OR to the ICU, Mr. Propofol plays the leading role for sedative hypnotics. Reliable, titratable. But remember, he is not here for your pain. That's someone else's job. Let's talk dosage. For induction of general anesthesia, the typical adult dose is about 2 to 2.5 milligram per kilogram IV push. In elderly or frail patients, start lower, closer to 1 to 1.5 milligram per kilogram. In healthy children, they may need 2.5 to 3.5 milligram per kilogram. Onset is rapid, 15 to 30 seconds. That's why we love it. Now, for TIVA, total intravenous anesthesia, this is often used in neuro cases and always for malignant hyperthermia, just to name a few real-world uses. Propofol is still used for induction, but also to maintain anesthesia with a continuous infusion. We combine it with short-acting opioids like remifentanil or fentanyl for pain control. Some monitoring protocols allow up to a half MAC of gas. If motors are not monitored, muscle relaxants are also allowed. Confirm with your hospital protocols. Also, TIVA is sometimes used for patients with known postoperative nausea and vomiting. Typical TIVA maintenance infusion rates for adults: 100 to 200 micrograms per kilogram per minute during surgery. Adjust based on patient response, age, and surgical stimulation. For sedation, much lower doses are used, around 25 to 75 micrograms per kilogram per minute. The key to TIVA is titration. Watch your patient's vitals and adjust in real time. TIVA is clean, elegant, and avoids inhalational gases, but it demands vigilance, finesse, and good synergy with analgesics and muscle relaxants.
All right, let's talk about me. The good, the bad, and the slightly stingy. First, the perks. I'm fast. I get you to sleep in seconds. I let you wake up smooth and clear. I don't cause much nausea. And I'm easy to titrate. Just a little finesse and boom. Perfect anesthetic depth. Now, I've got my little quirks too. I can drop your blood pressure. I may slow your breathing. I do burn a little on the way in. Sorry about that. Just think of it as sunshine in your vein. And listen, I won't touch your pain. That's not my gig. Bring opioids or locals for that party. Every superhero's got their kryptonite. Just make sure you know mine. Mr. Propofol. Now listen, I don't love talking about this next part, but I owe it to my ICU friends out there. We're talking about something rare, but real. Propofol Infusion Syndrome, or PRIS. It's serious stuff. We're talking metabolic acidosis, rhabdomyolysis, cardiac failure, and renal failure. This usually shows up in patients receiving high-dose, long-term infusions, especially over 48 hours, or doses above 4 milligrams per kilo per hour. But here's the part I do like to share. PRIS has not been reported during anesthesia, even in long surgeries. Still, if you're in the OR and a patient rolls in from the ICU who's been on a Propofol drip for a while, you need to know what to look for. If lactate starts to spike or CPK climbs, stop the infusion immediately. It's rare, but if it happens, you don't want to miss it.
Let's recap. Propofol is a short-acting IV sedative-hypnotic great for induction, sedation, and maintenance. Not a pain reliever. Know the dose, respect the risks, and use it wisely.
Well, you made it to the end, but can you pass my test? Time for a quick 5-question quiz. Winner gets bragging rights. Loser, still mildly sedated. Question 1. What's my primary mechanism of action? A. NMD. A. Antagonist. B. GABA A agonist. C. Alpha 2 agonist. D. Dopamine blocker. I'll give you a second. Think fast. Correct answer, B. GABAA agonist. I hit that GABA A receptor like a snooze button on steroids. Fewer signals equals lights out. And that, my friend, is pharmacology with flair. Question 2. How quickly do I kick in after a good old IV push? Option A. 2 to 3 minutes. Option B. 15 to 30 seconds. Option C. 5 to 10 minutes. Option D. 1 hour. Don't blink. You might miss it. B. 15 to 30 seconds is right. I'm basically the Flash of anesthetics. You push me, I'm already parking in the GABA lounge. Question 3. Which of the following is not a common reason to invite me into your veins? Option A. Induction of general anesthesia. Option B. Sedation for colonoscopy. Option C. Pain management. Option D. ICU sedation. I know I'm versatile, but even I have boundaries. The odd one out is option C. Pain management. Nope. That's not my gig. I don't do long-term relationships with pain. I'm the ghoster of consciousness. Question 4. How do I exit the party? Metabolically speaking? Option A. Renal excretion unchanged. Option B. Liver metabolism, then kidney excretion. Option C. Exhaled through the lungs. Option D. Metabolized in muscle tissue. It's a team effort, but who's on the roster? Answer. Option B. Liver, then kidney. I hit the liver first for a molecular makeover, then get passed off to the kidneys for final checkout. Teamwork makes the clearance work. Final one for this round. Question 5. What do I look like? Option A, clear and yellow. Option B, cloudy blue. Option C, milky white. Option D, neon green. Come on, if you've ever drawn me up, you know. Yep. Option C, milky white. It's my signature look. Smooth, creamy, and absolutely not even a flat white from that fancy coffee shop in the hospital lobby. Well, look who made it to the end. You either aced that quiz, or you're here for the sarcasm. Either way, I'm flattered. Do me a favor, hit that like button, smash subscribe, and comment how many you got right, unless it was 0. Then, maybe keep that to yourself. Let me know the next anesthesia bit you want to know more about. This has been your favorite milky white mystery in a vial, Mr. Propofol. I'll be seeing you in all the familiar places. Catch you next time on Anesthesia Bits.